All right, welcome everyone. Thank you for joining us today. Shaun, Brewster and Bodine here, back again, having a chat about all things hip and pelvis. So just about a week ago, we launched your baby that you've been building over the last probably nearly a year and a half. It's the hip and pelvis online course. It was a big project of yours, right?
Yeah, there's a lot of work that went into it, but I'm stoked to have it finished. It was great. I'm so passionate about the hip and pelvis region, and you know, being able to write it and spend the time recording it was a great experience. It was a long time, but I really enjoyed it, and I'm so happy now that it's out, released to the public, and other people can enjoy it as well.
Absolutely. And so today's discussion is not necessarily an advertisement for the course, but I thought we'd just bring up the fact that it is out there and it's available, and it's the exercise of building it, I guess, has been a really good one for you educationally, right? Like it's really deepened your understanding and knowledge of the area. It was already a specialty area of interest for you. But I can see what it's done, and that's to really give you this deep appreciation and understanding of the region.
Yeah, 100%. It's such a complex area, and there's so much great research around, and there's even more coming out, which is it's sort of hard to release it because you're like, oh, a new paper's come out. Should I add that in? So it's sort of this never-ending amount of information that's sort of coming out around the hip and pelvis. So it's awesome.
I'm sure you'll add that info as it comes out and gets released,
Yeah,
right? Yeah.
definitely.
So I thought what we might do today, I should say, is ask you a few questions to sort of give people who also have an interest or a need to understand this region better for their own clinical purposes, around some of the key things that will help them do a better job with their patients. And so some of the common mistakes they might make, and some of the maybe misconceptions that they may have around assessing, treating, managing, providing exercise for, and so on for the hip and pelvis. So why don't we start with what are some of the key screening protocols that people should be following when it comes to assessing this region?
Yeah, so I think firstly, when we look at someone presenting with hip pain, it's important not just to dive straight into looking at the hip. We need to keep a fairly open mind at the start and obviously rule out any serious pathology and rule out the lumbar spine. So going through some physical screens for that, such as neuro assessments, straight leg raises, slump tests, tendon reflex testing, sensory testing, all of that sort of stuff, assessing the myotomes, looking for any, if there's any loss of motor function. So we can be clear that the pain is not coming from the lumbar spine. But also note that there can be some somatic referred pain from the lumbar spine also. So we've always got to keep that in mind. Moving into the sacroiliac joint, screening that area and ruling out the sacroiliac joint. So then we can continue on with our physical assessment through the hip. So sort of structuring it that way can be a nice way to start from a physical point of view. But obviously, when we're looking at screening, taking a thorough history, there might even be some patient-reported outcome measures that we could look at as well, to assess sort of the psychological impact, the impact of stress and environmental factors that may be associated with that person's pain presentation.
Yeah, right. And the hip and pelvis region being so complex and having these various multiple layers of complexity when it comes to the structure and function, but also the psychological overlay that often comes with hip and pelvic related pain, especially someone who may have been through surgery in the region. Maybe they've had gone through giving birth, all of these different components that can layer the pain experience. It can really throw my clinicians, I think, when they first look at it, and you can get overwhelmed and maybe look at the hip and pelvis and go, right, I know 4 conditions. We've got arthritis, we've got FAI, we've got, XYZ. And they'll go, it must be one of those things, right? And they'll assess for one of those conditions, find a test that will point roughly to it, and go, well, that's what it must be, and I'll treat that. And then obviously, get it wrong a lot of the time as a result.
Yeah, definitely. And then even looking at, if you've got an athlete presenting with hip and groin pain versus someone who might be in their sort of early 40s presenting with hip and groin pain, starting to identify, well, what are the other factors that are associated with their pain presentation, the sort of amount of or the level of symptoms, the chronicity of their symptoms, because typically the more chronic they are, there may be multiple pathologies that are associated, but also the level of sensitivity increases. So it's hard to put our finger on one particular pathology that's the primary driver. And when we look at, for example, femoroacetabular impingement syndrome, it's sort of along a bit of a continuum where the pathology may actually start out, or I shouldn't say the pathology, the morphological variation that occurs at the head-neck junction in a CAM-type morphology actually occurs between the ages of 10 and 14 years of age. So they can have these morphological variations where they'll have what's called a greater alpha angle. So it's sort of a flattening of that head-neck junction. But that doesn't necessarily mean that that's pathological. All right. So we can't necessarily mistake morphology with pathology. But if you have someone who is highly active in the younger sort of adolescent period as they're growing, that could potentially lead into pathology by turning into a labral tear, where we have sort of compression from that head neck junction against the acetabular rim, or the chondrolabral junction, where we have then pathology at the acetabular labrum, and that could potentially progress to chondral changes and then early onset osteoarthritis. So although the morphological variation starts out quite early on, as that progresses over time, it's not necessarily the lesion or the morphological change that causes the pain. It's the onset of the symptoms from labral changes and osteoarthritis that may be where their symptoms come about. So that's where it can be quite complex, because you could look at someone's imaging report and see, well, they've got a higher alpha angle over 60 degrees, but that doesn't mean that they've got necessarily FAI unless they have symptoms associated with that and clinical signs.
Right. And this is the problem, right, with FAI, and we can dive into this in more detail a little later, but so many people that I've seen with FAI are in their middle-age years, 30s, 40s, 50s, and they've, doing an activity, cycling, running, whatever it might be, and they're getting this pain, and then they go to the GP, who sends them off for scans, and it comes back, and sure enough, you've got morphological changes, a CAM lesion, pincer lesion, or whatever. And in the case of the CAM lesion, like you're saying, happens most likely in adolescent years. If the surgical intervention was to shave away a piece of bone to try to clean up that morphological change, you're shaving away something that happened decades earlier. It was there all along, and it's clearly not the source of pain right now, because they've gone 2 or 3 decades without any pain, and now suddenly they're getting it. So it's really putting the cart before the horse there. It's not solving the problem at all. It's looking at the wrong thing. And I think this is the problem with a lot of presentations for hip and pelvis, right?
Yeah, definitely. It's an interesting one where, you could have morphological changes, but then, it's really about combining that with increased exercise intensity and volume. So from a management point of view, and someone that does present with it later in life, well, it could be that it's the management really comes back to exercise and activity modification. Obviously athletes are far more likely to present with FAI, symptomatic FAI, about 8 times more likely than the sedentary population. But yeah, that's the thing. It's sort of the continuum of pathology that often would lead to symptoms, because you could have what would be identified on imaging as a greater alpha angle, or a sort of a CAM type morphology, but doesn't necessarily mean that you're going to have a symptomatic FAI.
So is the solution then to just live a sedentary life? Is that what you're suggesting?
Well, no, because you will also find CAM type morphology in the sedentary population as well. So yeah, it's interesting. That's where it's still a bit of an unknown with athletic versus sedentary population and who will develop symptoms and why, but there is a stronger correlation with the athletic population and athletes with limited hip internal rotation, less than 20 degrees as well.
Right.
But yeah, I mean, stay active, but we've just got to monitor these symptoms when they.
It's easy when you take a fact like that and say where the morphological changes happen in those early years, and that couple that with the fact that increased activity, athletic activity, multiplies your chance of getting symptoms. You could look at those two things by themselves and say, well, the research tells me live a sedentary life. But in actual fact, if you look at things like tendinopathies, where someone is being more active, they're more likely to develop a tendinopathy, and then, well, maybe we should stop exercising. But now we know that exercise is the thing that manages the pain. So it's really probably the solution is somewhere in the middle of all that and say, well, let's reduce the load to something that's manageable, maintain it so we still have muscular and functional control of the region, and then work our way back out of it gradually. It's like a tissue capacity issue.
Yeah, definitely. And you even look at like the benefits of exercise is not just about the tissue, but it's the effect on our mood and our overall well-being. And you look at people that do typically have chronic pain, they're usually more on the sedentary side, and the influence of exercise can promote positive lifestyle changes, positive behavioral changes. And even when we look at, say, for example, osteoarthritis, or if someone's having FAI surgery, well, people that tend to have mood-related disorders, stress, anxiety, tend to have worse outcomes post-surgery as well. And they also tend to have lower pain thresholds. So, when we think about the benefits of exercise, is it really about changing what's happening at the tissue level? I mean, yeah, there could be certainly a component of that, but at a whole person level, I think that's really important. Sort of shifting that focus away from the specific tissue pathology in those chronic pain people.
Yeah, absolutely. There's also the whole concept of exercise-induced pain modulation. Like exercise is a great way to stop you experiencing pain. And then obviously it's a means to reduce the intensity of it when we do experience it. So no, we definitely don't want to stop exercising. All right, let's go and dive into one particular part of hip and pelvic pain, which is that deep gluteal region or deep gluteal source of neurological pain. Now, when I was going through school, if you had nerve pain shooting down the back of your leg that wasn't coming from your lower back, from your spine, it must, in 100% of cases, be a source of piriformis. Is the piriformis syndrome the source of all evil, like we were taught?
It's a funny one, isn't it? And it's sort of one that, like, I mean, so many patients will come in saying that they've got piriformis syndrome, and because it's painful when they press there, and there might be some sensory changes or motor changes into the posterior thigh. Well, it must be the piriformis. Well, unfortunately, there's a lot that can go on in that deep gluteal space, which is why it's no longer really called piriformis syndrome. It's referred to as deep gluteal syndrome. There's one, again, we have to rule out the lumbar spine. Most of the time when we have, any radicular pain, we've got to be looking at the lumbar spine. Once we can rule out that, then we can move into looking at any peripheral neuropathy or any entrapment syndromes within that deep gluteal space. But yeah, I mean, it can happen. Like, you can have a entrapment of the sciatic nerve from the piriformis, and the piriformis can go underneath. The sciatic nerve can go underneath the muscle. It can go through it. It can go over the top of it. It can split. So there's all sorts of different anatomical variations. But, it can also be the gemmellian obturator syndrome, where the sciatic nerve passes between the gemmellian obturator muscle, and it can have sort of like a scissoring effect on the sciatic nerve. Obviously, we've got to look at ischiofemoral impingement syndrome as well. So that can be a bit of a nasty one. It's common in more of your runners or people that have pain presenting in hip extension and hip adduction. So where the sciatic nerve passes lateral to the ischial tuberosity, the lesser trochanter of the femur can compress against the ischial tuberosity of the pelvis, which can cause irritation to the quadratus femoris muscle and swelling and atrophy, as well as sensitization to the sciatic nerve. So that can be another one, which is, as I said, more pain with hip extension and adduction. They might report clunking, clicking, catching when they're walking or running. So we've got to consider that, and even looking at any peripheral entrapment, in the hamstring of the sciatic nerve. So there's certainly some things to look at to start with. But also, like, obviously, as I said before, it might be painful to press over that area, over the piriformis. Well, if a nerve is sensitized, you press over that nerve, it's going to be painful. Right. So a good area to palpate for sciatic nerve sensitivity is just lateral to that ischial tuberosity. That can be a useful place to palpate for it. But I think when we look at if it's a true piriformis syndrome, then addressing and treating the piriformis should make some good changes. But it will have to correlate with the mechanism of injury of a piriformis syndrome, where they would either be doing sitting with their legs crossed for a long period of time, or doing a lot of hip abduction based exercises, or sitting on a wallet, or sitting on a hard surface that compresses that area. So it's a true piriformis syndrome, or a deep gluteal syndrome, is often worse when sitting for more than 20 minutes, but it will often be relieved when they stand up and walk. So having a look at some of those key signs can be really, really helpful.
Yeah, good. And I guess it's probably worth pointing out too, because I find this is always something that people will do wrong clinically in the management of a true piriformis syndrome, where we've got that anatomical variation or hypertonic piriformis maybe compressing that nerve and irritating it, is they'll dive in with an elbow or some kind of pressure tool and go, let's compress that tissue and just really pull it apart and rub it out. But what have we got? We've got a mechanosensitive nerve as a result of compression, and the treatment that we're prescribing is more compression. It just doesn't make sense. And so I think when it comes to nerve irritation, nerve sensitization, compression-based presentations, we have to move away from compressive techniques. And if you're a soft tissue therapist, most of what we do is compressive techniques. We squash the body, we squash stuff. So we have to think about each pathology on its own merits. Like, what is the mechanism of injury here? What is the mechanism of sensitization of this nerve? And then how can we unload the nerve rather than compress it further?
Yeah, exactly. And then, another common mistake is stretching. I feel pain there, so I'm going to stretch it. And often the advice given is to stretch it out. And once again, if you're doing a compressive technique to a nerve or stretching the nerve, that nerve can become ischemic, so limited blood flow. It can become fibrotic, and then that also impairs the conductivity of the nerve. So one of the best things to do, believe it or not, is neural mobilization or movement and exercise. So getting them moving, getting them exercising, and neurodynamic exercises can be a sort of a great segue into getting them more active and showing them that it's okay to move, and that neural mobilization is actually quite effective. And because one of the difficulties with nerve-based pathologies is often the symptoms get worse at night as well. So they're laying in bed, changes in body temperature, and their symptoms may increase. So showing them some neurodynamic exercises rather than doing static stretches, neurodynamic mobilizations, to promote some good blood flow through that nerve, can be really useful in desensitizing pain, but promoting longer term changes.
Absolutely. No, that's good. Some good key insights there. So let's look now at the other side of the pelvis, come around the front. So people will often present with, and I've seen this a lot clinically, is anterior hip pain. And obviously we've got a lot of structures in there: femoral nerve, hip flexors, labrum, a whole bunch of different things that could burst, so that could potentially be the source of hip pain. But I think a lot of the time we jump to the FAI, we jump to the hip flexors, because we can often palpate tight hip flexors, Or we know if we jam the hip up into hip flexion, add a bit of rotation, oh yeah, look, we're getting an impingement type sensation. How often is it actually FAI or hip flexor related with anterior hip pain?
Oh, such a good question. Like if we look at FAI or doing a Fadir test, so flexion, adduction, internal rotation. So yeah, most people will report symptoms with this because it's a highly sensitive test. It's got a sensitivity of 92%, but it's got a specificity of 8%. So that means that it's good to rule out intra-articular pathology if that test is negative, but it's not useful to rule in intra-articular pathology. It just means that we need to do further assessment.
Yeah.
So yeah, if someone's presenting with anterior hip and groin pain, that's a good place to start. Look at doing the Fadir test. Look at doing the anterior impingement test, which is very similar to the Fadir test, but we just take them to 90 degrees of hip flexion, internal rotation. And then looking at a prone hip internal rotation test. So face down on the table and moving them in with the knee flexed into hip internal rotation. And we're looking for pain and a recreation of symptoms or range of motion that's less than 20 degrees. Because if that test is positive, that has a very high specificity, meaning that it's better at ruling in FAI. So yes, clustering those tests together can give us an idea if femoroacetabular impingement is involved or if it is an intra-articular pathology. Because as I said before, I mean, yeah, they might have FAI, but they could also have sensitization through the anterior capsule and the labrum. They could have osteoarthritic changes through that area, but often, a lot of the time, the range of motion is limited and the pain is increased due to muscle guarding. So yeah, assessing that, but looking to settle down some of that muscle guarding and reassessing. So yeah, I'd be looking at that, number one, to sort of rule out intra-articular pathology. But then we have to differentiate if it's intra-articular pathology or extra-articular pathology. So when I say extra-articular pathology, I'm referring to like iliopectineal bursitis, iliopsoas tendinopathy or tear. It could be there's rectus femoris enthesopathy, tendinopathy or tear. And in its rarer cases, there can be a bit of a sartorius enthesopathy or tendinopathy there as well. But, differentiating intra-articular clicking, catching, grinding, all of those types of symptoms from that extra-articular pain. So that can be an important one, and it's really about starting to, there's various different special tests that you can do, but palpation is a useful assessment to do to see if we could specifically locate that area. But just to confuse you even more, obviously the iliopsoas goes directly over the anterior aspect of the hip, right? So it can assist in centralizing and stabilizing the anterior aspect of the acetabulofemoral joint and limiting that anterior shear force. So if you did have intra-articular pathology, well, sometimes you may have sensitization or irritation to that iliopsoas muscle in combination. So there could be a couple of things going on there, and that's where it can be really quite confusing, because you might palpate iliopsoas and it's really tender and it recreates their symptoms, but that could be as a result of something else. Complex area, and I won't even touch on acetabular dysplasia and anterior insufficiency because
there's a lot to absorb, obviously, here. And this is exactly why you wrote the course, right? Because there's so much complexity to it. And you can just see through, a couple of simple questions how much of a rabbit hole or a series of rabbit holes you can go down. And I think that presents a real challenge for most therapists, because most people don't learn to assess the pelvis thoroughly enough to be able to do a really good job with it. I think this is what you've done such a great job with the course, is because it really does go down each one of those rabbit holes to the very bottom to see what's there. So yeah, that's great.
And I think like the biggest thing is just having that list of differentials, and because Yeah, we could easily go in and say, well, this is what I think it is. But sometimes different things might respond a little bit differently or behave slightly differently. And when we're looking at acute management all the way through to chronic pain presentations in the management of that, we've got to have those differentials in the back of our mind and think, well, maybe it could be a little bit of this, or maybe there could also be some symptoms contributing from another area, and keeping that in mind in the total management.
Absolutely. All right. Well, one last thing then to wrap this up, and we're going to really struggle to not go down a rabbit hole in this one. But we often hear people talking about symmetry-based presentations when it comes to the hip and pelvis, leg length discrepancies, hemipelvis, torsions, rotations, hip hikes. And it's very easy to point to those asymmetrical presentations and go, well, that's obviously the source of your SIJ pain, your hip pain, your back pain, your pubic symphysis pain, whatever it might be, because they've got an asymmetrical load traveling through those joints. And then therefore that is the source of your pain. So to everyone who's a structural thinker, it's a beautiful model, right? That works quite well because you can see things, they're not straight, they're not square. If I can give them a heel lift, if I can mobilize this joint, if I can tighten this muscle, loosen this muscle, and create some kind of symmetry again, problem goes away. Now, I'm going to guess that you're going to tell me that's not the case.
Yeah, for sure. And that's the thing, like, we can't point at little mechanical and structural differentiations and differences and say that that's causative. Well, we don't know, and it's unlikely, for one, but two, it could be that that's a result, or that's a sort of a muscle guarding effect from the way they're moving. But it's also really disempowering, because if you tell someone that their pain is due to a leg length discrepancy, well, one, they've probably had that all of their life if it's a true leg length discrepancy. But two, how do you make their pain go away if you can't change their leg length discrepancy? All right. And three, let's say their pain does go away and the leg length didn't change. It's, well, how do you explain that?
Yeah.
Because we know we can get fantastic results with the right management, but when we start to blame sort of postural asymmetries as causative, it's really unreliable. And we see all sorts of morphological variations, differences in the position of ASIS and PSIS. It's unreliable to even say that someone's got an anterior pelvic tilt or a leg length discrepancy and all of this sort of stuff. So yeah, it's a good one to bring up for sure, because the hip and pain in general is far too complex to label structural abnormalities as causative, because we see all sorts of structural abnormalities in the asymptomatic population. So unfortunately, too simple to label that.
Yeah, I think, yeah, absolutely. And I think the skeptic in me thinks about, all those times when someone's presented with a leg length discrepancy or a hip hike on one side, of whether it's structural or functional or whatever, and they've gone to the therapist, and the therapist says, I can correct this for you, I can do some structural correction. And sure enough, they go to see that therapist and they might spend 5-6 weeks with them, multiple sessions, and then they get better. And it's very easy to go, well, we made a change there. Look, we've done a before and after photo and your hip's sitting in a better position. And we correlate that with the source of their pain, and therefore, the therapist was right. It could very well be the fact that over those 6 weeks, the person provided some positive sensory input to the body, which reduced the pain presentation. The patient then moved a little bit more than they would have otherwise, which then desensitized or would decrease their pain as well. They got a little stronger as a result. There's a belief that the treatments were improving their symmetry. They were moving better as a result. They were less guarding, less apprehension. And so with that reduced apprehension, then they feel a bit more confident and they do more things. And you can see all those things can go on as a result of the trust and the belief that application was the right thing. Now, more power to them. If that resolves the problem, then it kind of almost doesn't matter, except for the fact that if we make a claim to a patient and say, this is the source of your pain, and they get better, well, that's great. But what if they don't? What if then they walk away and go, well, that asymmetry, that leg length discrepancy, that rotated tibia, whatever it is the source of my pain. This practitioner couldn't fix it. Now the story going on inside the patient's head is, I'm stuck with this. And it spirals the other way. And that's very real. And I think that happens quite a bit with patients is, oh, I've got arthritis, I've got structural changes, I've got whatever. Therefore, this is my story now.
I couldn't agree with that more. Yeah. It's yeah, and that's the thing that leads to that therapist reliance, like and fear. Like I'm worried that this will come back, and then you know, and it's just sort of if we can promote positivity and reinforcement, you know, and safety and movement and all of these stuff, all of these things to create positive lifestyle changes and all of this, you know, that can decrease someone's overall pain experience is one of the best things that we can do. Yeah, it sort of, I mean, yeah, we need to have an understanding of structure and pathology and all of this sort of stuff. But, you know, in the long term is shifting away from that and focusing on more what they want to do and focusing on the person and getting them towards their goals. I think that's important in the overall management, regardless of the structural pathology or asymmetry or whatever.
That's right. Yeah. And I guess the key thing that I've taken away from today is like you look at that cam lesion in the hip, that cam morphology starting between the ages of 10 and 14. If that's the time that change happens in bone, but the person doesn't develop their pain until they're 47, how can we link any structural change to any pain? You know, there's so many more factors that have to play into it. And if someone has arthritis and they have pain 6 days out of 7, why on the 7th day are they having less pain? The arthritis is still there. You know, it can't just be the structure.
Exactly. Yeah.
Yeah. Yeah. All right, Bo. We many rabbit holes to explore here, but I think that's probably going to do us for today on that one. That's brilliant. So if anyone is interested in learning more about hip and pelvis, definitely check out Bo's course. He's done an amazing job. It's a behemoth. It's a big one. You don't dive into this course on a weekend and think you'll be done by Sunday afternoon. But there's a lot to it. Yeah, I tip of the hat to you for putting such a comprehensive program together. We've already got a stack of people doing this course, and I'm sure we're going to get some amazing feedback from them at the other end. So yeah, congratulations on that.
Thank you very much. It's been a pleasure.
Yeah, awesome. All right, we'll leave it there. Thanks, guys. Thanks for tuning in. We'll see you next time.
Cheers.